he ordered me to include pregnancy, newborn, and breastfeeding. So in the 30 minutes, I will give 10 minutes to each part of that. So there are three parts of my talk. But first of all, I have a comment on to Dr. Debussy that statistics is an essential part. How to interpret it, this is the thing. So we have to learn how to interpret the statistics. Otherwise, we cannot communicate to our parents, to ourselves, to our colleagues in a right way. So anyway, this is a long debate. We will do sometime else. Okay. So Amar, thank you very much. And we will go through something about COVID. As you all know, the COVID, I hope, inshallah, it is ending now, but still we have to address these issues, especially these tender conditions like pregnancy or tender age, like newborn or the breastfeeding. I have nothing to disclose. So as I said, there's a three parts. I divided this talk. First thing first, start with the pregnancy. At the beginning, 2020, we don't know that how is the relation in the pregnancy, the pregnant woman getting worse condition, the pregnant woman having the same thing. So this is the article published having the data. Again, we have to rely on the data, okay? But after validate this data, there are 215 pregnant women tested at admission for delivery, 15.4% COVID positive, but only 1.9% COVID symptomatic. So as you can see in this pie diagram, now the key takeaway from this risk of underestimating COVID-19 positivity in women delivering. So it can be possible that this article, which is published in New England Journal of Medicine, can underestimate. And this is only in the one center in New York, which is doing that. Then we have to have many other articles. It is by Figueroa Filhaud from Italy, Journal of Perinatology, again in 2021, that he published that systemic reviews. Now, this is the thing, I'm correlating because I have to talk about statistics because this is all COVID, you cannot talk about statistics. So systematic review is another way to get your reliable data. So this is the systematic review, and you can see that how huge review is. 8 studies, 11,000 cases distributed in 15 countries around the world until July 2020, which is the peak of the COVID at that time. So the result demonstrate that maternal characteristic, clinical symptom, maternal and neonatal outcome are not worse or different from the general population. So this is, they conclude that okay, they can have the COVID, but it is the severity of the disease is not affected by the pregnancy itself. The perinatal outcome might depend on T helper 1 and T helper 2 balance and to the state of the regulation of ACE2 receptor of the pregnant woman or pregnant mother. So that's the one of the thing they are thinking, that if they have the balance between T helper 1 and T helper 2 and the regulation of ACE2 receptors of the pregnant mother, then it can be the same. So the question arises in 2020, is COVID-19 a problem during pregnancy or delivery? Overall answer, we don't know at that time. Can COVID-19 be passed for a pregnant woman to the fetus or newborn? Yes, it is obvious. It can pass through this. I will give you some evidence and I will show you how it is. This is the very latest data. This is from the Children's Hospital of Philadelphia, CHOPS. And it is in CDC Mortality Morbidity Review in 2021, published in 11 October 2021. So they review the cases and the severity of the maternal illness. So look at this, is over 120,000 cases, and the total death out of that is only 180. So the severity is not that much. Okay, the pregnancy is not affecting the the lady that much during the COVID illness. Now, this is again published in March 31, 2020, One, this is the Lancet Global Health. The question is COVID-19 a problem during a pregnancy or delivery? If a pregnant woman has COVID-19 during pregnancy, will it hurt the baby? As you can see here, stillbirth, there is no difference. Okay, you see the p-value. High income countries, low and middle income countries, neonatal death is almost the same, maternal death is almost the same. The only thing is the one of the thing is a significant p-value is the maternal death, which is 530 events in the pandemic and 698 pre-pandemic. So the COVID is actually protecting the mother. So that's amazing. This is something different. Now, what happened? But really, COVID-19 can impact on the woman, and how it can impact the woman. So I use this publication. This Satyan is my one of the friend is in the Davis at California, University of California. He is very enthusiastic about, he's a neonatologist, by the way, and he make all these diagrams, and I'm using his diagrams with his permission. But anyway, in this article, it said that pregnant women with coronavirus disease are significantly more likely to be admitted to intensive care and receive invasive ventilation and ECMO. And mortality is also higher among pregnant women. So that's the thing, that we have a very conflicted or different or opposite studies. So what can happen to the mother during the COVID? In this study, they said headache is in 43%. The COVID positive mothers, pregnant ladies have fever in 32%, cough is 50%, shortness of breath, muscle aches, and then the respiratory compromise can happen. And when they analyze it, but the difference is not that much. So it is adjusted relative risk. So I know Debussy will not like it, but anyway, it is the adjusted relative risk. It is not the relative risk. It's not the adjusted risk. It's adjusted relative risk. I cannot go through the statistics here, but anyway, me and Debussy will do sometime a workshop on that. So symptomatic woman, ICU admission in pregnant, 23,000. So it is not the small studies. The number, look at this, is 24,000 almost ladies, is 1.05%, and non-pregnant is about 0.39%. So yes, there is some higher risk in the ICU admission. Invasive ventilation is almost the same, but a little bit, if you do the adjusted risk, is a little bit high. ECMO is again almost the same, but it is a little bit risk is there. Mortality is absolutely or almost the same, 0.15% and 0.1 or 0.12%. Risk higher. Age is 35 to 44 years, so higher increasing the age. So as other comorbidities in pregnant lady can happen in this condition also. They figure it out that Hispanic and African American is higher mortality, but there are many other reasons. There are socio-cultural condition, which condition they are living, and many other reasons. Maybe many of these, I'm not the bias, I'm not the race bias, but there are many social cultural problems in that races, because I live in USA for a while, so I know. So then Asian and Native Hawaiian Pacific Islander is ICU admission is more than others. How we transmit the mother, how the mother can transmit to the baby, there are 3-4 things. So let's see, the pregnant woman positive, the first week, the baby don't have it, but 2 to 4 weeks, the baby can have. And this is called late onset neonatal COVID. The mother negative, baby negative, but somebody else who come to visit the mother and the child, he can transmit. So this is also the late onset. The other possibility, the mother is positive, the baby become positive, it is early onset. And this is the higher chance to go into MISC, which is multi-inflammatory systemic disease of childhood, or N, which is neonatal. D, mother is positive and the baby remain negative. And this is the most common. We find it out here in our hospital at SSMC. E, the mother is positive and the kid can directly go into the inflammatory systemic multi-system disease of the neonate. So these are the 5 possibilities it can be transferred. But how the mother can transfer this thing by pathologically, there are 3 ways. Intrauterine transmission, of course, is the placenta. The virus can cross the placenta and affect the baby. The other is intrapartum, when the baby is passing through the vaginal or the birth canal, then it can, exposed to the feces, exposed to the infected maternal blood, or exposed to infected secretions, so the baby can. And the last is the immediate postpartum transmission. If the mother is positive and the baby and the not using the mask, not sanitizing the hand, and this thing. The breast milk I will talk in later about the breast milk. These are hundreds of studies, mainly from the Italy. Italy is, if you all remember, is hit by the COVID very much. So it's from China, Canada, Italy, Iran. And they are all talking about different things, that if the vertically transmission can happen or not. Some say yes, some say no. But I will, and how they confirm in the first case, the viral load by nasopharyngeal swab in the mother, vaginal swab, placenta, amniotic fluid, and blood. In the neonate, they took the blood, nasopharyngeal swab at day number of 1, rectal swab, then swab again at day of life 3 and day of life 18. And this is the viral load. So this is the first case, how they know that this can be transmitted vertically also. So the final answer, does it exit vertical transmission? The answer is yes. The COVID-19 in amniotic fluid and neonatal swab does not mean the vertical transmission, but it can happen. It is the possibility. Now, the clinical presentation of a COVID, we all go through it in the mother, that the mother had similar kind of a symptom, headache, fever, shortness of the breath, and physiological changes during the pregnancy. It happened there, respiratory compromise because of the many other things, and all this figure we already went through. These are the DOH latest guidelines, that how DOH is the Department of Health. Those who don't know, is the Department of Health is a regulatory authority in Abu Dhabi, which regulates the health institutions here in Abu Dhabi and United Arab Emirates. So this is the guidelines, that if the woman arrives at the hospital, woman should be provided surgical face mask on arrival, not to be removed until advised by the doctor, transferred to the receiving area. Then woman suspected or confirmed COVID-19 should go into the negative pressure room in receiving clinical area, and woman should be triaged by the obstetrician, who will be responsible for drafting the plan of care, should be informed. In labor, if the woman with suspected or confirmed COVID-19 should be admitted to the labor ward directly, but separate if they have the negative pressure room. If immediate in the emergency management is required, the woman should be taken directly to the designated appropriate clinical area. The recommended investigations are the PCR for the COVID-19. For inpatient, PCR test should be repeated every 72 hours until the negative. Blood for the full blood count, urea, electrolyte, liver function test, and the CRP. Other investigation for routine OB management, example CTG and ultrasound. So if you receive a mother and you suspect this thing, you can go through this algorithm. Now, the implications for the practice in the nurseries include how to approach to the delivery room, test to perform, management of the neonate, and decision on cohorting, breastfeeding, and feeding regimens. So we will see. Now, in delivery room, we have to have an extra cautious if we are delivering a mother with a COVID positive. So bag and mask, PPAS, ventilation, suction, continuous positive airway pressure, NIPPV, endotracheal intubation, mechanical ventilation, everything should be ready at the bedside. So these are the very nice diagram made by my friend Dr. Satyan. from California. So now look, the delivery of a newborn of a mother with COVID-19, the timing and the mode of the delivery and anesthesia in pregnant woman with suspected COVID-19 infection are dependent on OB indication. Okay, so it's the same. Cesarean section rate is 24 to 41% in pregnant women infected with COVID-19. So, but the cesarean section rate is higher in United States as compared to here. So let's say if the lady arrived to the birthing room or where they deliver, the nurse and the doctor has the complete PPE or as cover the N95 and goggles and cover the mask, face shield, gowns, gloves, everything. And the mother also has the mask, okay? So, which is very difficult because I attend personally one delivery at the time of the COVID. The mother is in so much pain, so much exhausted. She's always trying to remove the mask. So anyway, the doctors and the nurses should take care of that. Then there should be a barrier in the DR room after the delivery. The baby given to the neonatologist or the pediatrician who is available, and all of them should have the complete PPE. One person should be standby to limit the exposure, because sometimes the baby comes very sick and you need an extra help. Then this person can come in and again having the full gadgets on, and then try to resuscitate with other doctors. The neonatal resuscitation change for the COVID, we have to have a gown and gloves, N95, face shield, eye protection. This is usual. But the mask ventilation, when you are doing it, it's better to 2% technique. Why? Because it has to be a very good seal. Otherwise, the exposure to the what you call the vapors is very, very high. Okay, so you have to have a very good seal. So one person should hold the mask and the other person can do it. If you have a video laryngoscope and the baby needs the intubation, then it is better to have a video laryngoscope, because you cannot be near to the baby, and from that far you can see from the video, and then you can intubate the baby. So this is one of the things you take care of. Can we use current respiratory strategies? Yes, but these modifications which I told you, the only recommend modification for contemporary respiratory care, we have to use bacterial viral hydrophobic filters with the expiratory part of the system which attach to our ventilators. So these are the things which we tailored and do when we resuscitate the newborn. So these are the guidelines from from our regulatory authority, DOH. The skin to skin, it should be discouraged. We always give the baby to the mother if the baby is fine, and to get the skin to skin. But immediate skin to skin you should avoid and at the delivery room, but the later consider an aerosol because it is an aerosol generating environment. But later skin to skin is allowed when the mother shift to the normal room or their room, then it is fine. But initially you should avoid. Now, there's one question is again asked that we don't know exactly at this time whether COVID-19 can affect the health of the baby at the birth. So this is 2020 when the COVID is very high at the peak, but at that time the question is arise that is affect the baby or not. The COVID-19 infect units look mostly asymptomatic, but it is not true. I will go through it. Another article posed a question that coronavirus infections in neonates, this is a systematic review, the most recent and updated review on neonatal COVID-19, no significant change from what is stated in the March 2020, and it is in July 2020. So this is again, he knows me very well. Baraldi is from Torino, Italy, and they did a lot of studies regarding this with one of my friend, Dr. Paolo Manzoni. So what they found it out that limited burden, limited severity, few cases series so far from the China, Italy, Brazil, or Iran. Many of them, these are the four most countries, if you remember, initially hit by the COVID. Many of them are asymptomatic, room air for 75%, 30% have only mild respiratory distress, feeding instability, and fever. So this is up till the July 2020. Then, of course, the conditions, the psychological condition, the potential NIC organization change and potential family center care change is there. So we have to support all this thing at the time of the admission. Now come to the neonatal part, that how the neonate can affect. So as I told you, there are 3-4 things can happen: early onset, late onset, and direct MISCN. So the early onset COVID can happen if the baby got the COVID from the mother. So it's often asymptomatic, as we saw in the thing, but but if they become symptomatic, they have the similar kind of a picture as a baby come to you for rule out sepsis. Typical onset is 2 to 7 days for the early onset, temperature instability, loss of interest in the feeding, nasal congestions, flaring, irregular breathing, diarrhea, lethargy, blue discoloration. So it is the similar picture. So you have to consider the COVID plus of course, your usual rule out sepsis workup. Late onset sepsis, COVID can happen at 5 to 35 days. After birth, temperature instability, non-specific obesity at the X-ray, you can find lethargy, feeding intolerance, apnea, postnatal transmission, and leukocytosis, lymphopenia, thrombocytopenia. Now, in the sepsis, okay, in the late onset sepsis, in the neonate, leukocytosis or the leukopenia can happen. But here only the leukocytosis, and in the sepsis, lymphopenia is hardly can happen. It can happen, but it is much more is the leukopenia, and thrombocytopenia is common in both of the diseases. So the neonates with COVID-19 infection is again, it depends the ACE2 expression gene. ACE2 express is different in different part of the our system, from blood, spleen, bone marrow, and it is evident by many of the studies that this gene expression can give us the severity of the disease in the mother or the babies. How to manage this baby? Similar management as you are doing with any other condition in the neonate: the supplemental oxygen, respiratory support, fluid resuscitation, temperature control. If the baby is in the severe condition, then you try the CPAP and then go back to the nasal cannula or high flow nasal cannula. Sometime, of course, the baby needs endotracheal intubation, but I told you all the precaution by the aerosolization or the viral filter. You should take care of that. Now, what about using the steroids and the remdesivir, which is the antiviral? There is currently evidence for the use of antiviral medication and steroids in the neonate is lacking till date. So one of the two studies or the case reports in 22-day-old with severe late onset COVID who clinically improved and tolerated the treatment with the remdesivir. Another one, a 4-day-old with the early onset, is treated and received DEXA and convalescent plasma, required invasive ventilation until 13 days of age, and ultimately improved. So these are the two case reports are there, but otherwise it's a general things what we are doing. Now, this is the very severe form of disease, which is multi-inflammatory syndrome. C means children, N means neonate, and this can happen like a very severe thing, as you can see here. It's a myocarditis, increased troponin, increased BNP, coronary aneurysm. So that's why it looks like a Kawasaki also, hypotension, hypoperfusion. But remember, Kawasaki, the major criteria is the fever for 5 days. This is the major criteria. If the no fever for 5 days, there cannot be a Kawasaki if you have all signs and symptoms of Kawasaki, or it can be the atypical Kawasaki. So these are the things which we go through it. This is a 49-day male infant whose family member tested positive when the infant was 2 weeks. He presented with severe GI manifestation, hypoalbuminemia, severe anemia, D-dimers, D-range, and thrombocytosis. So this is the severe form of the disease. How to deal with that? You have to check the BNP and it is elevated. You have to do the echocardiography, showed mitral regurgitation, coronary arteries. The infant was treated with IVIG and plus methylprednisolone. And this condition, they use the steroid as similar as a Kawasaki disease. So IVIG and pulse methylprednisolone is the treatment of choice. These are just the algorithm for the same thing. Third and the last part, the breastfeeding and the COVID-19. There's a lot of things going on with the breastfeeding. I am pro breastfeeding. I am biased about that. So I am go through it. This is the first 3 to 4 months of life, the most critical, and since the only protection device from maternal external antibodies. But the thing is that the timing of immunological response is associated with windows of the risk. So we have to see that how the antibodies are transferred. So let's see a different aspect, but which is the viral condition, which is called the bronchiolitis. Look at this. The breastfeed infant is here and the formula feed infant is here. The chances of having probability of hospitalization for bronchiolitis, which is RSV most commonly in Italian cohort, is much higher in a formula-fed babies as compared to the breastfeeding baby. This is one thing. Second thing is the breastfeeding contains the lactoferrin, which is standard formula milk don't contain the lactoferrin. So the lactoferrin supplementation was associated with significantly fewer lower respiratory tract illness. So this is another thing. So we have to encourage the breastfeeding in any case of the disease. And there's another study about the lactoferrin. Now, is COVID-19 a problem for breastfeeding? The current answer, which is published in 2020 and then again in 2021, now is no. Okay, so there is no positive breast milk sample have been found in different reported cohorts for total number of 47 dyads with only one exception. So mother and 47 mother and the babies, only one has this that it is transferred. So the conclusion is the risk for passage of the virus from mother to infant during breastfeeding, if any, should therefore be associated with close maternal neonate contact rather than the possibility that the virus is transmitted through the milk. So yes, as I told you in my early slides, that if the mother is not taking care with the mask or hand sanitizer or hand hygiene, then of course the baby can get COVID. Again, there's a multi-center Italian study from Torino, Italy, human milk from 14 breastfeeding mothers positive for COVID-19. All 14 newborn underwent a clinical follow-up. In 13 cases, the search for COVID-19 in milk sample negative, only one is positive, okay? This data support the view that COVID-19 positive mothers do not expose their newborns to an additional risk of infection by breastfeeding. Early identification of IgA, anti-SARS-CoV in the milk, yes. There is the IgA and the anti-SARS or COVID antibodies in the milk. So the presence of the SARS-CoV-2 IgA in the milk of the mothers infected with COVID-19 may be related to protection against the transmission and severity of the disease. So the breast milk is very essential. So we should continue taking some precautions. So that's why this is the conclusion of all the biggest associations of pediatrics. So the AAP, American Academy of Pediatrics, Dr. Karen Papillo, she was just in our conference of neonatology, and she recommend that to consider separating mother and neonate is only in some situation. I will show you in a minute. Same by the Italian European Union, same by the French Pediatric, same by the Brazilian Pediatric, and same by the UK Royal College for Pediatric and the Child Health. So what is the thing? This is the chart I want to give to all those units which is dealing with the COVID, that you have to check the health status of the mother, then the pharyngeal swab, and pharyngeal swab of the neonate, isolation of the mother, yes, management of the neonate, in rooming in, you can do it, okay, and advise on direct breastfeeding, yes, and preventive measure, of course, yes. The only condition when the mother is very symptomatic and very sick, you took the swab of the mother or already being done, then if the mother is positive, then you take the baby swab also, then keep the mother in isolated area, then of course you transfer the baby to NICU and keep it isolated. But still, you continue with the express breast milk. Direct breastfeeding, yes, you cannot, but ask the mother to express the milk, and no need for pasteurization or anything, and you just continue with the breast milk. So this is the only condition when the mother is sick and symptomatic, you just isolate the baby. Breastfeeding in term infant born to the mother with COVID-19, again, I told you, is a protective antibodies is there. Antiviral, if you are using in a mother, is no adverse event, but it is these studies done in the Ebola period. In Ebola period, we use the same remdesivir antiviral, and there is no side effect, and it is not find it out that the breast milk transmit this antiviral. So the Academy of Breastfeeding Medicine does not recommend cessation of breastfeeding when lactating mother receive mRNA-based liposomal vaccine also. Long term, we don't know because it is only 2 years old, this or 1 year, 1.5 year old disease. So we don't know, but whatever it is that the assumption is that it can happen if the kids have a severe disease, then chronic airway inflammation or asthma can be a possibility. Okay, last over 2 slides about the vaccine in the pregnancy and the breastfeeding. This is the American Journal of Pathology, just published 1 month ago, vaccine during pregnancy and breastfeeding. And they said that whether to get vaccine during pregnancy or breastfeeding is the mother choice. But they recommended that it's better, but still, decision to get the vaccine is based on your personal risk of COVID-19. Your risk exposure might be high if you are health worker exposed to the public, enforcement, restaurant, and all those. So if you are in a low risk, you might deny to take the vaccine. But if you are in a risk, like example, if you are in healthcare worker or age more than 35, then you can take the vaccines. The side effects of the vaccine is the similar as non-pregnant or the or any other who is taking the vaccine. This is the preliminary findings. mRNA is again April 2021. It's published in the, I think in the New England Journal. The safety in the pregnant, no red flags so far. So this is a safe, no stillbirth, no maybe the preterm birth, but there's no such difference. And this is a very safe vaccine during the pregnancy. How much is the antibodies? Because this is the unpublished data, because Dr. Karen Popilo knows me very well, so she shared with me. Asymptomatic, you have a very low antibodies unit. Symptomatic, you have a little bit. With Moderna, you have quite a bit similar with the Pfizer, a little bit more with the Pfizer vaccine. They didn't test for the Sinopharm vaccine, but this is the very unpublished data. So to summarize it, the COVID-19 pandemic is unprecedented challenge for all the healthcare system, whether it is adult or the pediatrics or the neonatology. It can affect all the age group. All children may be the carrier of the virus. So that's why we take care of that. GI symptoms and the fecal-oral transmission are frequent in the children. Vertical transmission might occur. Neonate can be asymptomatic, but you have to test them. Breastfeeding is not a contraindicated in most of the cases, except one situation which I showed you. The advent of the vaccines in the present scenario Okay, something happened. I don't know what. Okay. Just somebody shared the slide. I'm finishing. If a large enough population were to be immunized by the vaccine, transmission may be reduced, as we are seeing now at this part of the year, that everywhere all the countries have a low COVID positive result because of the vaccination. It remains to be seen if asymptomatic viral carriage will be affected by the widespread vaccination, though it is plausible that this will also decrease. However, again and again, in the absence of strict masking, hand washing, and social distancing, viral transmission may continue in spite of vaccination. So those high prevalence areas, they have to be very, very cautious and continue to have strict masking, hand washing, and social distancing. That's all from my side, and thanks a lot. And sorry if I take 2-3 more minutes. Back to you, Amar.
Thank you very much, Junaid. That's really very well evidenced, very informative, and covers the raised questions. There are quite a few questions from the audience, so I will take you through them quickly, if possible, knowing the limitation of time. You know, there is a story here of a neonate born to a mother. Is there an increased risk of neonates, COVID-positive mothers, babies to develop RDS, in particular respiratory distress syndrome? You know, babies born to positive mothers.
No, that's actually I have, because again there's a lot of things with the premature babies. I didn't touch that section. The premature babies continue to have their own premature problems. So, for example, I'm reading it. They are 33 weeks. 33 weeks can have the RDS. Okay, so this baby has RDS, but it is not because of the COVID positive. Okay, so there is no relation between the respiratory distress syndrome and the COVID, and it is evident that there is no relationship with that.
Okay, there was the question from Taha. Mahmoud says that if a symptomatic pregnant woman comes in with labor, you know, they tend to just do a rapid PCR, and also, if needed, they do a chest X-ray to exclude pneumonia. Will do or not? What are your most important precautions measures in these cases?
Yeah, as I showed you in the picture, that you have to have a complete PPE. Okay, you have to separate the L&D, where the babies, doctors, and the baby resuscitate, and there's another one. Just minimize the doctors and the nurses ratio if a normal delivery. But of course, these are the extra precautions you have to take, which I showed you early in my thing.
Yeah, and then Hinda, I think, asked the question you've already answered. Really, do you recommend COVID vaccination for pregnant mothers?
Yes. So if the lady is in the high risk, so for example, the nurse is working with us in NICU or the hospital, and they are pregnant, so we recommend them to take the vaccine, because I showed you there is no red flags with the vaccine and the pregnancy, so they can easily take the vaccine.
Yes, there are so many questions really. Nabiha says, can we rely on serological tests to diagnose vertical transmission in neonates born to pregnant women with COVID?
Yeah, I said in my first couple of slides that can happen occasionally, but the serology, but the positivity of the test, it does not guarantee that it is the vertical transmission. So this is we have to say.
Yeah, in the same regard, you know, Dawlat asks us, you know, that all the data points towards the safety of vaccination in pregnant women. Why do we prohibit it till now?
Again, what?
Well, why is it prohibited? Says why it is prohibited till this moment that pregnant women are not given the vaccination according to her thoughts.
Okay, so because we don't have the data, okay, this is the first publication which I showed you in the March, in the April 2021, whatever the date, that it shows that there is no side effect, no stillbirth, no prematurity, no premature labor happen. So after this, that they allow it, and still I showed you the figure or the diagram from the Journal of Perinatology, which is published, that it's still they put it in the on the patient themselves, that okay, if you are not in a very high risk condition, and if you contain yourself, if you are not going outside, you are not in the healthcare worker or something like that, so it's up to you. But if you are that, if your age is more than 35, and if you are doing these kind of things, and if you are exposed to these things, then it's better to take the vaccine.
I'm trying to be sensitive here. Somebody is asking about handling breast milk of infected mother in terms of infection control. Handling breast milk of infected mother. Any special precautions with that?
Okay, there's no special precaution. So similar thing, the mother should have the hand hygiene as any mother. She should have the mask, covered with the mask. She should do the hand sanitizer. And after that, she express the milk in a clean bottle and give it to the nurse or somebody. So this is no extra precaution. It's the same what we are doing for any other lady. Of course, they have to wash their hand. They have to clean themselves. Only the difference is they have to cover. If they are positive, the mother is positive, then she has to cover herself with the mask.
Yeah, Nadeem Ali asks, is there any difference in terms of safety and effectiveness of giving vaccine to pregnant mothers?
You mean if we give early or if we give late?
Yes. Yes.
Yeah,
yes.
it is. See, that's the thing. It is not. There's no difference, and the thing is that the article which I showed you, they all mentioned in the last trimester, that what can happen in the last trimester: start of premature labor, stillbirth, miscarriage. So at any time they can give the vaccine, because they find it out there is no effect on the fetus or the embryo, not the embryo, but the fetus and the baby later on. So they can give in any trimester. So that's why now it's open. Everybody doing this.
Butane asks us about, and among patients with COVID, they tend to become hypercoagulable, and pregnancy is hypercoagulable state.
Yeah.
So is there any much more increased risk of clotting problems?
This is a good question, but we don't have any evidence about that. The pregnancy is hypercoagulable stage, yes, and the COVID is a hypercoagulable state, but we have a lot of COVID cases in one of our sister hospital. Our hospital also, time to time, at the time of the COVID, especially in 2020, we have a lot of women, but we couldn't find anything. But I am telling you that it is not reported, and there is no such thing in the literature so far. Maybe later on it will come.
Thank you very much, Khan. That's very informative. Really, I have to stop reading the questions because there are too many. I believe the topic is very interesting to everybody.
Okay,
so
I will try to answer during the next talk. Okay, so don't worry about that.
Please, thank you.
Thank
now
you.
we'll